but I'll probably just bring my laptop up here. That way I have it on it, so I'm not like.
Oh, you get a copy of your presentation there?
Yeah.
Okay.
That's what I'm saying. So that way you. So how are you gonna know when? Okay, so I don't control it. I tell you this next. I have to say next slide. Huh? All right.
There you go. Bye, golly. Hello, 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 hello. I could use this one. I just have to lean in. There. Cool. All right. It's the witching hour plus a couple minutes. So if you all would rise and remove your covers and join me in the Pledge of Allegiance. Buford, you all right? Doing the two-step? Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, liberty and justice for all. Excellent. Thank you all. Please be seated and relax. Welcome. It's been a long time since we've seen all these smiling faces collected together. I think our last meeting was in October. So this is just going to be a quick state of the team presentation tonight from me. Jerry will weigh in. Jeff will talk about the TEACS course, pediatrics course coming up at the end of the month. Lauren will go over a few items on the AO side since Kathy's gone, and then we'll break. After break, we'll come back, and then Marilyn's going to do a presentation for us tonight on crush injuries. So, you got it? All right. So, this is my best buddy, Emmett. And you know what Emmett always says, that lovely song, everything is awesome. So that's kind of what, that's going to be our theme for this year. Everything is awesome. because we have a lot of changes we're going to talk about. There's going to be a lot of things that are going to impact the team going forward this year. We have a lot of cool things that are already in the works, and we're going to talk about those tonight. We got housekeeping stuff as far as new policies and procedures we're going to go over, and then of course general discussion for any items that we need to bring to the table. Clarence says he can't hear. Complimentary Q-tips are back there in my bag. All right. So what's been happening? Basically, this is everything that's kind of rolled out since October. Legislation was passed in Washington that gives us FICA coverage, and we'll talk about that. But essentially, we now have effective workers' compensation. The code of conduct requirements are in place, and we are officially abiding by them. We'll talk about that. Fitness for duty, it's now being tested. We'll go address some of the parameters that are involved with that. The active employee definition is now in place and active. So there's three policies and procedures that have now been rolled out with signatures affixed. We have extended our agreement with Owens, so we have a home for calendar 2016. We have a fundamentals rotation that's going to be executed here in another week and a half or so. The hiring freeze continues. The team profile is changing. They're looking at some team typing things. We'll talk about that. And they're assessing and analyzing all of the DMAT teams in the system. So we'll cover all that as we go forward. All right. So the first thing that we want to talk about is rostering. And again, since they're doing the analysis and the evaluations of the teams, here's our report card. Because what they're going to do is they're looking at what the teams have, how many employees the teams have, what type of team that they are, and how successful they have been in rostering their team type profile for the on-month calls. So, and this is a little bit light, and I apologize for that, but I was trying to do 5 things at one time when I put this together today. So anyhow, going back to November 14th last year. So we're going back, this is November of 14. This is because it's 15 months. That was our first month as a type 2 team, having reduced because we couldn't fill the 50 profile. So as you go down the column there, team personnel on the profile was 35. We used 1 backfill person. We had 5 additional people that we put on that roster as reserve. So technically, OH-1 was able to roster 40 personnel out of the 80 at that time. We were at 93 personnel at that point. So we were able to roster 40 people out of our team complement. The next month that we rostered up was January of 15. Again, we're a type 2 team. That means we have our required footprint is 35 personnel. We used 1 backfill person again, and we had 2 in reserve. So we effectively were able to only roster 37 people out of 93 for the month of on-call. In April of 15, we had, let's see, well, again, footprints 35, but we were able to roster 33. We had to use 3 backfill, and we only had 4 in reserve. So 37 was all we were able to come up with that had made themselves available to roster. And in July of 15, we were able to roster 33 personnel. We backfilled 3. We had 4 in reserve, which means we had 37. And that is our report card according to Mr. HQ Director. So what they're doing with this is they are going through, and they have an independent agency from another department that is looking at all aspects of each team individually. And this is their jump off point. What has that team been able to do with the number of people that they have in the 4 months of on-call cycle. Then they're looking at the accountability rosters. They're also pulling the data on completion of mandatory training. They're also looking at submissions of mandatory required documentation. Also looking at whether or not that is posted and how it's posted in RMS. So they're looking at our AO processes as well. And they're going to utilize this to reclassify some teams. And there are teams out there that honestly stayed type 1 teams, which meant that they were they said they made a commitment that they could roster 50 people on a consistent basis, and they've barely been able to roster 35. So they're backfilling 25 people every month that they're on call. So there's going to be a come to Jesus meeting for a lot of teams. I think we're going to come under scrutiny, but it's not going to be as ugly as what it's going to be for a lot of the teams. Part of the problem that we have is that we have a very limited number of physicians, and we have a very limited number of nurse practitioners and PAs, and we have one mental health person, and those are our criticality Achilles heels. And you have 4 rostering periods out of the year. You only have 2 or 3 docs. You're not going to be able to put your docs out, especially when they want you to send. When they want you in your roster, you're supposed to have 3 docs. You're supposed to have 2 mid-levels. You're supposed to have a mental health person. Dr. Laux is, he's department chair. He can get out. He does roster his minimum of 2 times a year, and he does extra stuff for us as well. But we only have 1 mental health person. So, you can only spread, everybody can only be spread so far. And I understand. And I'm going to go when it's my time. I will go and I will defend everything that we do. I know that the people that are engaged on the team and have made the commitment to come to meetings and get their work done are always the first to step forward to roster, first to step forward to go, hey, I'll go train. We have people here that may not get rostered with our team, but you know what? They're jumping on rosters with other teams in our off months. That all has value, and I think that all has to count, and that's what I'm going to submit when I get my time in the hot seat. So, but anyhow, that's what's kind of going on. We're limited, honestly, by the freeze. We did have the freeze. We'll come back to freeze again, but the freeze was lifted and the freeze was reinstated, and the freeze is going to stay frozen for a while, it sounds like. Their processes, they thought they had a process, and the process failed horribly because there were positions. We had openings. Remember, and I announced, I think it was in September, October, that the freeze was being lifted. We're going to open up positions for physicians, nurses moving up within the pay grades of nursing, and mid-levels, PAs and NP. System-wide, between all the teams, there were 430 plus people that applied for positions that were posted. Only 22 were selected because 410 or 12 people did not do their USA Jobs profile completion the right way. So of course the commanders took the heat because we didn't follow through and teach people how to do it. I'm sorry. This team here, and I know a majority of the other teams this has been such a horrendous experience for the last 3.5 years, going to be 4 years in May, that when they finally said they were going to open stuff up, I contacted every person that I knew was going to apply for a merit promotion or to come in from the outside, okay, personally. I walked them through the process on USA Jobs. I walked them through what they had to submit, and we didn't get one. So you know what? It's not for lack of effort on my part. It's not for a lack of effort on this team's part to try to coach candidates and actually even active employees into how to submit all the items on a list of 12 items. So, so 412 people failed horribly. After they came at us, we immediately turned it back and they shut it off and said, well, we have to redo our process again. So that's where the freeze is. Okay, next, sir. So we have pain, and I wanted to share with you a little improved pain scale that I ran across, because not only is the hiring freeze been painful, but we have other things that are going to cause great pain. And I think that we should all consistently be able to describe our pain purely by using the new improved pain scale. So I'm figuring mauled by a bear is probably going to be close. And that's number 9. All right, sir. Okay, so the great news. Okay, because again, you know, good news, bad news, bitter and the sweet. We got FICA, guys. And, you know, I mean, I've been real upfront and describing how we got kind of led down the primrose path when it came to workers' compensation. I pledged to join the fight along with the other commanders and working through the process in Washington to get us appropriate coverage. Historically, for those of you that aren't up to speed on what occurred, we've always been told, being intermittent employees, that we had workers' compensation coverage. And that was half true and half not true. Because if you were injured on a deployment during training, when we're covered under USERRA, when you're on orders, you know, that if they deemed it a compensable injury, then they would pay for the medical. So they pay for your medical treatment. So if you broke your leg, you had to have surgery, you know what? They pay for your ER, they pay for your surgery, they pay for your follow-up medical until you reach the point of maximum medical improvement. Once you're medically discharged, then your workers' compensation coverage for the medical exposure would cease. What they didn't tell us all over the years was that if we got injured on a deployment or a training period under USERRA and orders, that there was no methodology in place to provide for payment to an individual if they were injured and they came off a deployment, went home, and could not go to work, which is an integral component of workers' compensation. Because we were intermittent employees, they had no way of capturing a snapshot of what our wage potential was as a special government employee. So basically, when you go out on a workers' comp injury and you're off of work, they look retroactively at your last 52 weeks that you worked and how much you made. And they take the average of that 52 weeks, and then they pay you 66 2/3 tax-free. Okay. Well, if you're only on duty for 14 days, and you're at a GS 9 or 10, or you know, if they're paying you whatever, let's just grab numbers, $18 an hour, okay, and there was no method to pay you. So therefore, if you were injured on the deployment, you came home and you couldn't work, you were screwed, because there was no coverage at all. When we finally discovered this, we obviously, with the management working group and the commanders, not only when we were at the commanders meetings in Arizona the last 2 years, but also, you know, there was one-to-one discussions with the director and also with the assistant secretary, one-to-one. I mean, I know I bent Mr. Boyce's ear several times, Dr. Garrett's ear several times, one-to-one, and we made this the highest of priorities as far as consistently fighting to get something done to mitigate this whole process and mitigate the issue. We found out that what had to happen was that legislatively, there had to be new law passed that included special government employees and reclassified them as federal full-time employees. And that is what FICA does. So they tagged this bill last year, well, in 2015, 2014 and 2015 on probably 9 or 10 different pieces of legislation. The last report that we had in September was that every one of them had failed. But then this evolved and arrived in email here just a couple months ago. And obviously I forwarded this to everybody as soon as it hit, because this is probably the biggest thing that's happened for us during my tenure in NDMS, and that's going back even into the 80s. So this is huge for us. You guys now can honestly take a deep breath and know that if in fact, you know, we go out the door and something does happen and you incur an injury, that you will be treated as a full-time federal employee when it comes to your benefits, calculations of your benefit in consideration. So this was a huge, huge win. It took Dr. Lori, the ASPR, the assistant secretary, the OEM director. I mean, there have been so many politicians involved in this process. It's impossible to even list everyone, but it's done, guys, and we have it. So this was the best Christmas present we could have gotten as a system. All right, next, sir. Code of conduct. Everybody got a copy. And if you didn't read it, or if you can't find your copy, you can get on Responder eLearn, or you can reach out to me and I'll send you a copy, because we had to have paperwork submitted, and we've passed our deadline. And we have people on the team who have not submitted the certificate that states that they completed the online training. So we are non-compliant, and this is a black eye on our team audit that they're doing on us right now. So the reason that they're making this mandatory is HQ is validating that every employee of NDMS understands how they're to act, what they can and can't say, and what they can and cannot do in public, whether they're wearing the uniform or even theoretically, you know, when we're off duty being federal special government employees. So if you haven't read it, you need to read it. If you've read it and you've taken the course but you haven't submitted the certificate, please, what are you doing? Are you dancing? Please get your certificates copied out and get them to Kathy so that we can take this piece off of our plate and we can go from being in the red to being in the black for this particular audit item. Again, the mentors have been involved. Kathy has sent, and I noticed, I know latest emails have been a little terse, but you know, it's one of those things too where, you know, we've been working on this for quite some time to get it in. The majority, again, this is the way it works. The majority of all of us do what we're supposed to do, and we get it done in a timely manner. There's always a handful. So, but at any rate, the handful now has an impact on the team because of the auditing that's in place. So if you don't have it done, get it done. Next, fitness for duty. This one is a bugaboo. Okay, we've talked about the fitness for duty as it's been evolving, and you know, the CMO shop, Dr. Davis, this is Dr. Davis's project, and they've been trying to push this and push this and push this. And you know, we were supposed to be on a self-reporting phase now where we're all supposed to be able to do a mile in, what was it, 15 minutes on level ground with no backpack, 15 or 18 minutes. Well, now they have an occupational medicine doc who's part of the CMO shop, who is now our NDMS risk manager. And the risk manager has calculated out what the physical requirements are of any individual who is involved in setting up a base of operation. Yeah, I know. And working in a booth. And so they came up with, I think it was 400 watts that a person has to generate to be able to do that. They have these tables and charts and geez, and they came up with the fact that if you're going to go on a deployment, if you're going to go on and have a base of operation, you have to be able to prove that you can walk 2 miles in 30 minutes with up to 10% of your body weight added, with a maximum of 25 pounds. And that is in place, and the folks that are going to Anniston in a week and a half are going to be tested to meet this metric. What we will see going forward is that when we go, no, if you look at the paperwork that we sent out to each person that's going, this is what they're going to be tested at. I reread it today. I thought it was a level 1 too until I reread it today because the orders came through, and I was like, oh my God. So they did change it. And again, what are they going to do if you can't do it? They don't know, guys. Okay, but the thing of it is that they're saying, well, you know what? You have to be physically fit. I don't know if they're just trying to call the herd here or what. Obviously, this is going to have a huge impact on the system because if you look at the mean age in NDMS on the DMAT teams is 56 or 57 years of age. Okay, so you know we have an aging population. Put your hand on the screen and say, I believe. And you know, this is now that they're so focused on risk management and workers' compensation, they want to create a young man's, young lady's environment where these people can go out and at least not incur additional workers' compensation exposures, falling over from MIs, blowing knees and shoulders and stuff because we're arthritic and we're old and we haven't recognized that here we're still 22, but here we're older and dirt. So, you know, this is a challenge, and all I'm going to say is that, you know, they don't have a plan other than they're going to test. If you go to Anniston, if we go on a deployment for a national security event, okay, and we're the backup team and we're at Frederick, 1, you're going to have to bill it in Naboo. There's no more hotels. 2, they're going to make you do this, observed. We can't do this within the team because of the liability that's involved. Because as far as I'm concerned, and we've discussed this many times over, they're making this quote unquote mandatory in kind of a backdoor way. But for us to sit here and have part of the meeting show up at 5, we'll go out and we'll walk the track. What if somebody twists their ankle? What if somebody falls over and has an MI? You know, what if somebody kicks somebody else in the shin and breaks their tibia? You know, it may be mandatory, but if we're not on government time with appropriate, adequate safety EMS people standing by, then we're not going to do it on the teams. But each individual really honestly needs to be able to at least do that, minimally do that mile. So I would just encourage everyone, again, from a fitness perspective, get out and walk, get on your treadmill. You know, they're trying to they're pushing wellness by trying to force us to do things, and so this is their big one. This has been coming. We've been talking about it for a couple of years. And you go to if you go to the MOB Center and they test you and you flunk, what are they going to do with you? They don't know. We tossed that at them at the last commander's meeting, last commander's call. So what are you going to say? Well, maybe we'll put them in IRCT. What? Yes. Yeah, that's heavy. Yeah. Oh, it's huge. The miler is not a casual walk either. Yeah. Yep. So you're just halving it. You're halving it. 4 miles an hour is damn near a jog. That's close. That's close. So us folk with bad knees, yeah, well, and the thing of it is, it's a conditioning thing. This is something you got to work on. So anyhow, I just want you guys to be aware. Yeah, that's the bitter that goes with this, because they're geared up for this fitness for duty thing, and there's a lot of screaming, hair pulling, teeth gnashing going on, but they're surging forward with it. So, you know, again, there were supposed to be self-reporting forms submitted. We have some folks that haven't done them. If you haven't done yours, yes. Okay. Everybody should know if you've done it or not. If not, you can double check the list because it's back there. And there are forms that you can go ahead and do your self-reporting, because at this point in time, as a team, we're non-compliant with the reporting component of the miler. So, all right, next. Oh, I wish. Yeah. Hello, kitty. I found this. Had to share it with you guys, especially as much fun as we've had with Hello Kitty over the years. All right, active employee. So you know what? That new policy came out. Hey, that new policy came out and was distributed by email from me to you all, being forwarded from the director. And this basically talks about what our requirements are and what our commitment is that we're making to NDMS, because we're being driven by HR and attorneys. So I would say if you have not read it, you need to read it. and you need to embrace it because we are bound by it. And go ahead and switch up to the next one, please. This policy does outline the requirements of remaining an employee. It also outlines accountability, and it does set the basis for interventions, which will start at the team level and have the propensity to become an HQ issue in very short order. So basically what this is going to say, and I just put up the stuff having to do with rostering, because that's going to be, that's our first big bugaboo, is rostering. Be on the team. Be an actively engaged employee in HHS. If your team rosters 4 months out of the year, 4 times a year, every employee is required to roster 2 times a year. Long and short of it, there's a whole bunch of other verbiage that goes along with it. You can read it, you can digest it, you can crumple it up, throw it in the basket, you can wipe body parts. But the bottom line is that everyone on the team, everybody who is a federal employee, is required to roster 2 times a year. Okay? So that is why every year we always put out the on-call roster months a year in advance so people can plan accordingly. And we continue to do that. How are those crackers? Oh, mama. So we continue to do that. We did it again. We posted this out, I think, in September, October of last year, so people could appropriately try to balance their time and plan ahead. Remember, we say 2-week availability. If you say I'm available on the 1st and the 2nd, you're not available because you can't be gone 2 weeks. If you say, I got to be back by the 14th, then you're not available. You have to be available for 14 days plus. It's on the REL. March. March. This is the longest break we've had without being rostered in all the time I've been on the team. We've been down for 4 months. So March is our first one, and I think then we're up in June, and I think we got September, and I think we have this December. Yeah. So, and that's on the Responder eLearn, and we'll talk about it. I've got that posted. We got the meeting dates posted. We're going to be working over into the new portal soon, so it'll be easier for you to assimilate this information. But bottom line is, that's the requirement for DMAT. Now, if you're DMAT and you're MAC, or JPATS, or EMR, you got to pick up another. You got to pick up another 1 to 2 calls in a year. I just think it's asking way too much of people because we can't even fill our own team roster without doing backfill. But bottom line is we have a large MAC contingent here. We have JPATS instructors. We have EMR instructors. Everybody does what they can. So you know what? Bless you. My position on this whole policy and procedure thing is yeah, we have to have the 2 times a year. If your JPATS MAC once will count, and I don't care. That fulfills the obligation. It shows them a little bit of sweat equity coming back for the investment they made for training. And again, we have people that are constantly going out the door, serving in other capacities. So that's where the accountability log comes into play, because it may not all be necessarily relatively related to our DMAT, but if you go out the door with another team, that's a check mark in the rostering as far as I'm concerned. If you roster with another team, you're rostering. If we cannot fill our own rosters from within our team, then we'll cut back on our rostering with other teams. But bottom line is, anytime you step forward and you make yourself available, you're going to get credit for being accountable and being engaged. So, all right, next. Owens, well, we had the boss here. We gave him a presentation, and they said, you got a place to stay. Well, we do have a place to stay. This is our room. We provided a schedule. Jared and I met with the powers that be, and we gave them our schedule, and they committed to us that we have a home for the year. This is our designated room. They've also offered out that we could, if we want, meet back in the at the Center for Emergency Preparedness building. So, this is a nice room. They have the same AV, same internet access back there. We're gonna be back there for the TEACS class. We'll look at it, and I'll take it to the TLG and let the group make a decision as to whether or not we want to move back there or stay here. But as it stands right now, this is where we meet every month or through the October meeting. If there is any changes to the scheduled meeting room, so if they come up with, if there's something that pops up that they want to override us for another event, they'll let us know. They'll give us an alternate room to meet in. We'll send an email out so everybody can adjust accordingly. The other thing is when on campus, wear your federal ID. We need to identify who we are. We're considered honored guests here. We're also, yes, sir. No, because we're not attending TEACS class as a federal employee. We come here as a federal employee. The question? I didn't ask a question. Oh, Jeffy's question. You want Jeffy's question? Jeffy's question was, oh, I didn't ask any questions. I'm imparting information, not gathering. Jeff's question was, if for those attending the TEACS class, do they need to wear an ID? Then the response was, as you heard it, no, because that's not a federal event. That is a state event under DHS funding. So when you come to team meetings, wear an ID. Get in the habit, and TEACS, negative. Next. Well, nursing is a profession where rolling fatties means something entirely different. Just a little jocular humor here. So, speaking of nurses, we have to talk about promotions and position needs. Like my segue. Like, oh. All right, so there's going to be, obviously we're still in the freeze, but as soon as the freeze lifts, the first thing they're going to do is they're going to open up commanders positions because there's several teams that don't have commanders. And teams that can have deputy commanders, which are only type 1 teams, will hire for their deputy commander position. Once that hiring phase is over, which should be a 2-week period, then we're going to roll into our hiring. And so I wanted to give you an idea of what our priorities are going to be when the freeze is up. The first thing that we're going to do is we're going to do internal promotions. So, who gets promoted? We have some docs that need to move up in their GS scales. We have nurses who have completed their nurse practitioner's education and have completed a year of clinical practice and are ready to move up. We have nurses who have been hired in at GS 9s. They've created new tiers of GS scales in all the job descriptions, the clinicals. So physicians, nurse practitioners, nurses, paramedics, pharmacists, pharmacy techs, and respiratory therapists are all have new tiers so that you can actually move up and increase your GS scales. So we're gonna roll through the nursing. We also have to groom some new nursing supervisory people. So we're going to have at least one of those open up. EMT paramedics will be the next round after the RTs, and then we're going to start bumping some people up there as well. And so that is good. We're going to do the internals first. We've had some attrition in the last few months. I'm predicting a little bit more of attrition, probably 1 or 2 more people max. And then when we get through the promotions, then I'm going to go into the second column, which is going to be the new hire priorities. We had a mental health. Dr. Locks has been by himself for a long time. And he feels real bad that he can't be here for us all the time. He can't roster. And we've always had at least 2 people in our mental health cadre. And one of our former mental health people who served with Dr. Luton, Sandy, she got married. She had twins. Her twins are grown up now enough that, and life has changed enough that she's ready to come back to the team. So she's going to be the first priority hire of new hires, is to bring her back on. so that we have too deep on the mental health. We have to hire new docs. We have two docs in our waiting pool. We have 3 nurse practitioners and PAs in the wings that have been patiently waiting. I'm in the process of transferring in a nurse practitioner from California 6. Paperwork has been submitted with my signature. I'm awaiting the signature of Dr. Jacoby from San Diego to finalize that transfer, and we will be up 1 new nurse practitioner. We need to get Andy up in the IT position per his request. And last but not least, we have to have a new training officer. And that is going to be a big priority for us. Right, as it stands right now, we have no internal and no one internally has stepped forward wanting to move up into a training capacity on the team. So when the time comes, we'll probably go to market on that one. If no one decides between now and then that they would like to move up. You know, I mean, Jeff's been doing it a long, long time. Jeff has some other career things that are evolving for him. And, you know, Zip is finishing up his residency. He comes out of his residency in 5 months. He's coming back as a doc. He's flying back into the team as a physician. So we're down to 1 trainer. That's Jeff. Jeff is probably not going to be serving in this capacity much longer. And he's also made it well known to us on the TLG that he wants to step back away from the training position. Training position is a non-clinical position. That's the bugaboo. Now, that's something that they're addressing at HQ, and we've been trying to get it changed for a couple of years. You know, and it very well may evolve that the training officer can be a clinical person again, but at the present time, it's not. So again, I'll continue to poll within the team if anybody wants to talk about it. You know, obviously you can talk to Jeff, you can talk to me, you can talk to anybody on the TLG, talk to Jer, Kat. But bottom line is we need to be grooming a new person to be the training officer. There's a lot to learn. There's a lot of processes that have to be assimilated to be effective in it. And it's not something you can just say, I'll be the trainer and have Jeff throw you a pile of paper and a laptop and go, there you go. It's far more involved than that. So we're looking for one really, really good person that can handle it, that has a passion, that likes training and wants to take what we've been doing. And Jeff's done an excellent job for the last few years since he took it over. You know, wants somebody to step up and say, I want to raise the bar and take it a little bit higher. So if you know of anybody on the team that description fits, kick them in the slats, tell them to step up. Okay. Other policy and procedure that's come out is social media. I don't know, Lauren, is the P&P for social media on Responder either? Did we post this? I don't know if it is or not. So I have it on my laptop because I reviewed all these today. I'll send this around for everybody so you can all see it again. If I didn't, if you don't have it already, just to understand that it's pretty in depth. And the take-home message is, you can use social media by policy and procedure according to HQ, but not when you're on active duty. So during active duty hours on a deployment, you can't use anything. And when you do, there's a whole list. Go ahead to the next one, please. One, they give you a list of everything that they're monitoring. They monitor the crap out of all this stuff. Yes? We can email it. Yeah, let's save that one and put that on the new platform when we roll out our new. We can have a section on there for P&Ps and just start loading that because they're going to start killing us with this stuff. So at any rate, the social media platforms, now if they list them, they're obviously watching them. So you know, you go putting pictures, you go putting stuff in. It's better to just not do it if you're deployed. You know, if you're going to take pictures and stuff like that, we have to vet all that stuff now. So you just can't go ahead. I mean, and everybody's been really good about it. The deployments where we've sent people out in the last year, everybody usually everybody that has wanted to has reached out to me personally and said, can I put this up? And they've sent me copies of the pictures. I copy them off to Washington. The PIO people look at it. They send me an email back and say, fine, that's cool. And that's the process. You just can't randomly put stuff up. videos, photos. If there's photos that have people's faces that are not part of our team or another team, if you don't have a release, don't even think about it. So this policy is very in-depth. There's a list upon list upon list of exclusionary things that you're not yet. Read it, guys. Bottom line is, we're on deployment, staff social media, or vet it through whoever your command person is on that deployment. We'll vet it back to me, and we'll vet it to the HQ PIO. Speaking of PIOs, I've been designated now the official PIO for the team by Washington. So I'm learning some new tricks and working on some dialogues and scripts so that I can be more effective in that role. But I tried to submit a couple people from the team into that role, but they're isolating it down to just team commanders now to serve in the function as a PIO. So next. Boy, that was a really good day. Golly dang it. We had a good time. And this is a preview of coming distractions. So, and this, happy things. We have bad things. We got policies and procedures. But we have happy times. We go do fun stuff. All right, next, please. So what do we got coming up? All right, we've got a group going to Anniston. There's 5 going to Anniston in a week and a half. And Brother Beetlejuice is going to be our command representation on that little sortie. See Dave Walters, Kathy Jenks, Beetlejuice, Anita, who else? Who's the 5th? Kurt Koenig are going to be our illustrious representatives down at Anniston. New fundamentals format this time. They've changed the program. This is going to be supposedly far more intensive from a clinical perspective, in addition to building the boo and working out of the boo, and also having the ice at the end with all the classes that are occurring at the same time, having that mass casualty event. The 180th Air Wing is going to do a repeat expanded in May of this year. We've been invited. I acknowledged that we would participate. It's going to include a hostage mass casualty incident on one of the aircraft. They're trying to figure out how they can role play us into that from a medical perspective, us in Michigan 1. We're looking at possibly a way of doing a boo somewhere, not on the Air Force Base, but doing an overnight. It's tentative. So as soon as the planning group is meeting monthly. The next planning meeting is on February the 6th or 7th. So they were supposed to anchor the dates at that point in time. So I'll send that around. Michigan 1 is going to send down a large contingent for this as well. So we're trying to see if we can either do 2 men in a truck here somewhere, or get the Michigan response team's trailer and their tents, which are the same thing, Western Shelters, and us coming up with a spot to throw the tents up and billet everybody for a weekend. We're talking, but there's potential. And even if we don't do the overnight thing for that weekend, we're going to play. We're going to go and get involved. So those that want to go can. The other thing that this overlaps is this is potentially the weekend that we were going to do the Michigan 1, Ohio 1 field exercise up at Fort Custer, Michigan. So depending on the outcomes of the planning meeting at DOD in a couple weeks, we're probably going to push that joint training back to September. And against, because Michigan's not, and they're hosting. So if we can participate, cool. Well, I mean, if we only roster 30 people and we have 80 some on the team, somebody should be able to go to Michigan. And if you go, you can always take your gear. And again, this is all just discussion. I'm just giving you a preview of coming distractions. These are things that are in the process. People are talking about them, and so that you're aware that we're not just sitting around like a lollipop or a fudge sickle planted on our thumbs and spinning. There's a lot of people doing a lot of work outside of this team to try to open up some opportunities for us to train. So, Toledo Air Show, another possibility. They're having a planning meeting coming up where they're going to talk about medical needs in the upcoming week or two, according to an email that I received from Scotty today. So, you know, it very well may be that, you know, an opportunity arises for us to participate in that. I think the last time we did that was in 2004, somewhere around in there. I think that was the last air show. Yeah. So we haven't done an air show in a long, long time. It would be really cool if they opened that up. No. The TEACS course is on the 30th and 31st of this month. And Jeff will give us a quick overview when I pass this off to him. And of course, we have national special security events coming up. We've got the RNC and the DNC this year. And one of them is in Ohio. So there's a possibility. Yes. Oh, hey, that's why you have U.S. Marshals. In Cleveland. Oh, yeah, yeah. Yeah. Oh, yeah. So, at any rate, that's just kind of, that's lots of stuff hanging out there. Plus, we have our on-call months. You don't know what the weather's going to do. It's been an El Nino year for us. So sad, too bad for Washington, D.C. It's supposed to be predicted to get 2 foot of snow in the next, what, 40 hours, 48 hours, something like that. Eastern Seaboard's getting whacked. This is, they're calling this now an epic storm. So it'll be interesting to see it, but we're not on call. Yep. Yep. So, yeah. Current events. Flint. Don't drink the water. You thought you guys' water sucked here with green algae? Go up to Flint. Oh, that's nasty. That is nasty. Oh, there's going to be so many heads that roll for all that. And I was listening to some stuff on NPR. The mayor of Flint was on when I was driving over. Oh, God, I tell you what. Yeah, well, you know what? There was an attorney on yesterday that's filed suit that says that basically that they're charging people for water. They're trying to nullify all the water bills. They're saying, how can you bill us for water when we can't use it? I thought it was a pretty novel idea, but I mean, they're just lining up. And of course, this is a huge social cultural issue too up there. So it's going to be interesting to see. But HHS is the lead agency for the Flint response in the water. So and that's why I'm sending out some of the sit reps with a little more frequency now, the daily briefing stuff, just so you can kind of see what's going on. The other thing that's been evolving is Zika virus, chikungunya virus, and what's the other one? Dengue. All three of those have become quite prominent in our hemisphere, specifically evolving out of South America, the Caribbean. We have states. Of course, you know, we're a mobile society, so we have Zika stateside, we have dengue, and we have chikungunya, all in the United States. So these are being. I think there was some policies and procedures and protocols for testing of pregnant women now. So, yeah, preview coming distractions. The other big thing in latest and greatest, Indiana is leading the way this year with the H9N7. We just wiped out 250,000 turkeys and chickens on one farm, and that farm is being terminally decontaminated. All the birds are being buried and incinerated, and so Indiana is leading the way this year. Indiana was the only state in the Midwest that avoided it last year, but this is a new strain. It's a new novel. It hasn't jumped over yet. So keep your eye on the sit reps, because it'll be interesting to see where this goes. Okay. Here's our meeting calendar for 16. This is on REL. I've sent this out in the emails too, so y'all can mark your calendars. These are our meeting dates. Every one of them is at 7 p.m. in this room unless otherwise notified. Okay. That's all I have. I'm sure you're tired of listening to what I've been ranting on along about. It's almost 8. Or don't. I'll let you do that. Yeah, I wanted to do that. Mhm. Oh, there! I haven't seen that do that since the last meeting. Nice. All right. Um, one other thing, then we're going to take a break. Um, we have one of our original longtime employees is here with us tonight, and she has submitted her resignation from the team, and I wanted to just publicly thank Barb for all the years that you have spent on this team and your service to us, to the nation. She's one of the people on this team went to ground zero. You went to Guam. Did you make Guam? You did. Did you go to Andrew? No. But Barbie's been with us a long time. She's been a critical part of the leadership group, the management of the team. Um, she was one of the people that mentored me when I came on board. Her and JVR and Jim Fenn were just critical in nurturing me and a lot of people that came after me into our roles on this team, and has been an anchor in making this team as successful as it's been. Unfortunately, I don't have everything compiled together yet to be able to do your shadow box. So I want you to come back. So that we can give you your shadow box. I got to. Hey, you know what? We'll talk. I'll give you my inventory list of what I have. But guys, a round of applause for Thank you, Barb. We all love you. All right, let's take a quick 5. Everybody, if you got to tap a kidney, tap it, and then we're going to move right into crush injuries, and then with Marilyn, and then we'll get everybody out the door. So we'll reconvene in a couple minutes after 8. You want to call mommy? Say mommy.
Mommy?
Where's your mommy? Say it again.
Mommy?
Call her again.
Mommy?
One more time.
Mommy?
Here, say mommy, mommy.
Mommy? Mommy?
Thank you, sir. Ta-da. Mommy. She's curious. She's curious what's going on. Can't be back there. Lift something you can get hurt with. Yep, you might want to go back to your mommy.
7:30, so we can get all the stuff situated, paperwork, make sure we have it. Not only like you're on our roster, you're not there, I'll look at it. You're on the road. Next week, Saturday. It's at the Center of Emergency Preparedness. Great fact, buy the old fire, fire, building. But beyond that, go to the dead end, to the right. Very funny. So uniform, no ID, not a federal employee, right? So if available, let me know. Like that. Hopefully by March 1st, I'll have an idea. Right. Computer mic'd up? Yep. You see that movie in the Metro House, Maryland Life. Mic'd up or you want,
Pocket very well. It's got a pocket, but it doesn't have like a real pocket.
Well,
is that better?
no, I'll get it from back. I gotta get it backstage.
Be like it, Chris.
Where was it supposed to be? Here? Now when I put this up. Huh?
And then if so you can see any questions that pop up. Right over here.
Oh, so I didn't know that was.
I just put it here. But this will also, that's going to be the delay. So
So I'll know the delay by that.
right.
And then,
Online.
okay.
All right.
All right. Can you hear me? All right. All right, if you guys need to talk louder, let me know. So, huh? Well, I don't have a pocket, so I can talk louder. I can talk. Don't worry. All right, so we're going to talk about crush injuries. If some of you were at the Michigan event, you may have already heard this, so hopefully it's a good review and not just another boring thing you've already heard. For other people, then hopefully it's educational. Go ahead, next. So the objectives are here. I'm not going to read this to you, but basically we're going to talk about crush injuries and crush syndrome. They're two separate things. And then also talk about the secondary complications you can see from the crush injury. Okay. Crush injury refers to the injury that occurs to the area of the body that ends up being crushed, whether it's a leg, an arm, the torso, and it causes localized muscle and nerve damage. You can see these in natural disasters as well as man-made disasters. Both can have patients where they're crushed under objects. And again, the injury refers to the specific area that was crushed versus the syndrome. Why doesn't this thing go? All right. Why is mine? Okay, go ahead. Yeah, you're good. So the incidence is greatest in the lower extremities, much smaller incidence in the upper extremities and the trunk, with approximately 10% of each of those areas. Go ahead. And go ahead. So what's going here is not what's going. Okay. All right, I'll just see where you're at there because it's not coming up here. So don't worry about it. It's no big deal. So crush syndrome was first described in World War II with bombing in London. And there they saw that patients who are people that had crush injuries were also having dark urine and having renal failure. And then this led to people recognizing the crush syndrome. Go ahead. And what it is you get systemic manifestations related to the crush of the tissues that occurs. With traumatic rhabdomyolysis, which is the breakdown of the injured muscle. And this causes the toxic muscle cell components to be released, and it also causes the escape of causes electrolyte imbalances with escape of potassium out of the cells, as well as the injured cells can sequester calcium, which can cause hypokalemia, and then these can cause circulatory difficulties, which we'll go through in more detail here shortly. Commonly, you can see crush injuries and crush syndrome in earthquake patients. The incidence based on historical data is 2 to 15%. Of the patients that do develop crush injury, 15 or 50% of them will develop acute renal failure related to the rhabdomyolysis that occurs. And if that 50% that develops acute renal failure, 50% of them are going to go on to actually require dialysis, which can be a dilemma when you're in a mass casualty disaster type situation. And then 50% of the casualties also require fasciotomies, because to the extent that the muscles swell, then needs a fasciotomy to try to preserve any further death of the muscle that does remain. Local tissue injury occurs, again, with resulting organ dysfunction and metabolic abnormalities. Okay? And this is just a schematic that goes through what we've talked about. Fluid retention occurs into the extremity that's injured related to third spacing, and this can be pretty profound and actually result in hypotension of the patient. So fluid resuscitation is key. The myoglobinuria that occurs can result in the renal failure we discussed, and then the cardiac arrhythmias that can develop from the metabolic electrolyte imbalances. With regards to electrolyte imbalances, acidosis occurs related to the death of the muscle cells. And again, the potassium comes out of the cells that are dying and can cause profound hyperkalemia. And then also the injured cells get leaky capillary or get leaky cell wall membranes, and the systemic calcium that can go inside the cells and then result in hypokalemia. And so this part of the slide's reversed, but what you're going to get is your normal QRS. You're going to start getting a peak T wave as you get the electrolyte imbalances. And then your QRS is also going to start to widen until you get kind of the sign out sign, where you go in more of a sinusoid rhythm, and then ultimately the patient's going to arrest from that. So it's important to stay up on top of these imbalances and to correct them. Go ahead. This is a picture of a patient who sustained a crush injury to the pelvis, and then secondarily had a crush syndrome develop. And as you can imagine, the upper thighs, the buttocks, has a fair amount of muscle tissue. So that's a lot of toxins that's going to be released into the system to cause the crush syndrome. Okay. Sorry. And also you have to be careful of reperfusion syndrome. When these patients are injured or crushed, then you have to take and lift, whether it's heavy concrete or whatever kind of object, or a car, whatever's they're trapped under. When you release that, then all of a sudden the tissues that have built up in those muscles can then escape into the circulatory system and then cause circulatory arrest. So you really got to be cognizant of this before you just release the patient from the object that they're pinned under. It's key that you perform adequate fluid resuscitation before releasing the patient from what they're crushed underneath. And the ideal fluid is normal saline. And casualties that are crushed for more than 4 hours are prone to abnormal neurologic or vascular, having abnormal neurologic or vascular injuries. However, you can still have these circulatory problems develop even when somebody's been crushed less than 4 hours. Again, give them 1 to 2 liters of normal saline before removing the object, if at all possible. If you can't treat the patient with normal saline prior to removing the object off of them, then you could use a tourniquet. This would allow the abrupt rush of the electrolytes out of the damaged tissue into the circulatory system. And then once you can get the patient in a situation where you could get an IV established and establish the IV, then give them fluid resuscitation before taking the tourniquet off. Use bicarbonate. This can help with the electrolyte imbalances since it's an acidotic situation. Also, bicarb is used sometimes in patients with rhabdomyolysis to help try to reduce the incidence of renal failure. Mannitol can, go ahead. No. Well, one, you're not going to be able to do that in the but no, I mean, typically peritoneal it's a hemodialysis. You mean to prevent the, huh? No. Peritoneal dialysis is used more for patients who are in end-stage renal disease chronically, and it's just another alternative method. Mannitol can be used. People often use it. There's been literature to support it, as well as literature to say that there is no benefit. If you've got it, you can give it to them. You're not going to hurt the patient by utilizing it. And what it does is tries to get the patient to diurese, keep the myoglobin moving through the renal tubule so it doesn't precipitate and cause the renal failure. Thing is even if you're using the mannitol, you still need to keep the volume going, because the key is to keep the patient peeing ideally like 150 to 200 an hour, if at all possible. Sometimes that can be difficult if you have a elderly patient who has significant CHF, but if you can, that you want to try to keep them peeing that fast. Okay, go ahead. Again, acute hypovolemia, which results from the loss of fluid into the tissues because of the injury in the third spacing fluid there and the metabolic abnormalities that we've already talked about. We already just kind of went through this here with regards to the bicarbonate. For hyperkalemia, use calcium, sodium bicarbonate, insulin D5W. Thing to remember about the calcium is the calcium is not going to treat the hyperkalemia. It's used to stabilize the membranes of the cells so that they're less irritable while you're taking and correcting the hyperkalemia with your sodium bicarbonate and your insulin D5W to shove the potassium into the cells. And then you also use calcium for the hypokalemia that develops, again, because the calcium can go across the walls of the cells into the injured muscle cells, and then that causes your systemic depletion of calcium. And if there is a delay of longer than 12 hours, this dramatically increases the risk of renal failure. So it's key to start hydrating these patients as fast as you can. Okay. On to the next slide. Regards to secondary complications, compartment syndrome, and what it is the muscles, again, swell up, and then the muscles are all encased by a layer of tissue called the fascia. And so as the damaged muscle expands with swelling, it's being compressed, it's entrapped. And so you need to relieve that pressure by incising the skin, overlying the muscle as well as the fascia, so that the muscle can basically swell up as much as it needs to, and not be trapped with increasing pressure because it can't expand. You should consider this compartment syndrome in all patients that have any type of crush injury, and it's been found to occur even in patients who've been trapped less than 1 hour. And oftentimes people think that you have to have a fracture present in the extremity to have a compartment syndrome, but that is not the case. Just the injury to the muscle itself without a fracture. So if you have the luxury of getting an x-ray and there's no fracture, don't get a false sense that they can't go on to develop a compartment syndrome. We talk about the 5 Ps with regards to the symptoms of compartment syndrome, and those are listed here. Pain, pallor, paresthesias, numbing, the patient has numbness, tingling in the extremity, pain with passive movement, meaning if you move the patient's foot or leg, they have pain. It doesn't have to just be when they're moving it. And then pulselessness. The main thing to remember is you don't want to wait until you have these 5 things, because then you've kind of missed the boat on the diagnosis. You want to be able to recognize it before all 5 of these occur, and be able to get your fasciotomy performed to give the best chance of salvage to the muscle and the extremity. One of the cardinal symptoms of compartment syndrome is pain out of proportion to the apparent injury. So if the patient is complaining of pain, a lot of pain, even though that may not look that bad of an injury to you, be suspicious that a compartment syndrome may be occurring. And the way to determine if a compartment syndrome is present, you can do compartment pressures. You can measure this directly by using a little instrument, a Stryker instrument, which puts a needle, and you can measure the pressure within the muscle compartment. Or also you can use the diastolic blood pressure minus the compartment pressure. Thing is in a disaster type situation, the ability to do this may be difficult. So you may just have to go more with your clinical judgment. This just shows a patient who had a fasciotomy for compartment syndrome. You can see the muscle or the skin, the subcutaneous tissue, and then that layer, like I said, the fascia, which is kind of a thick, whitish type layer, which you don't see here because now it's all retracted back. All those layers have been cut, And now you can see the muscle, how it's bulging out because it's swollen. And this needs to be done in order to prevent further damage to the nerves, the vascular system, as well as the muscles. And then with regards to wound care of extremities that are, it doesn't have to just be extremities, but whatever part of the body's been injured or crushed, the key is debridement of the necrotic tissue. To stay ahead of any dead tissue, get rid of it, especially because this can also instigate renal failure if it's left to be. Also be sure the patient has a tetanus toxoid, and then use antibiotics if the wound's infected and you can't just get ahead of it by surgically debriding it. And especially in the case of a disaster type setting, if there is associated infections, they're going to be polymicrobial, not just a single organism, so you need to use broad spectrum antibiotic coverage. Field amputation should be a last resort unless there's no other way of getting the patient extricated and out of there. I prefer not to have, ideally you'd prefer not to have to do an extremity amputation, but unfortunately occasionally it does occur. You don't want to be doing this? Hopefully none of us have to be doing that, but was there a slide back? Okay. No, go ahead. Go forward. Go forward. Oh, go forward. Okay. I was thinking morbidity came before mortality, so that's why. With regards to early mortality, it's related to the hypolipolemia as well as the cardiac arrhythmias that can develop from the hyperkalemia. Okay. And then the late mortality results from sepsis related to the associated infections, and then also multiple organ failure. Not only the kidneys, but also they can go into like an ARDS, respiratory failure. They can have multi-system failure if they have these injuries aren't addressed rapidly. Okay. And then factors affecting mortality as well as morbidity is the severity of the crush injury. Again, the timing of treatment, how quickly can you get them? Do you find them? Have they been crushed for several days before they're found, or is it just an hour or two? And then dependent upon the initial treatment you're able to provide the victim. Any questions? You could have a fracture in that extremity, obviously, but also associated fractures in the rest of their body would be a concern. Especially, did they fall a distance before they landed wherever they landed at, a piece of concrete or an object they're on. So there you may have spine injuries, other extremity injuries, rib fractures. Head injuries could be, they may be head injuries as well. If they got crushed and as they went down, they banged their head. So yeah, you gotta think of them as potentially a multi-trauma patient. Right. And if there's if there was an explosion related to causing the rubble that they're now trapped under, then you got to think of blast type injuries too, which could be pneumothoraces, eardrum injuries. Yeah, but chances are, we're not going to be able to do that. mean, that's going to be something they would do once they get them out of the disaster scene. Sorry. Would what? I mean, that's a war that's been, I mean, from a trauma surgery standpoint, I mean, that's a war that's been going on for decades about do you resuscitate with colloid or crystalloid? And in our setting, I mean, you've been deployed a lot more than me. I mean, do we even have the ability for any colloids? Yeah, because when yeah. I mean, what they really need is the volume. I mean, your crystalloid's going to be, I mean, in my mind, use the crystalloid. You know, or there's some people that may say, oh, the colloid. But I mean, for what you need for this, crystalloid, give them normal saline. And, you know, if you only had LR, you could give them LR. It's got a little bit of potassium in it, but it's not that much. But I mean, ideally, normal saline is what I would use. And the thing is, too, with the colloids, I mean, you're not going to give them huge volumes of it. It's going to be small amounts. You're still going to need your crystalloid for the extent of resuscitation you need to get these people to pee as fast as they need to get this myoglobin to keep moving through and not precipitate. Yeah, no, it's quick. I mean, as soon as you reestablish blood flow to that extremity that's had its blood flow cut off, it's gonna, yeah. So, and you can also, with the bicarb that we talked about, because I don't know if I specifically said it, but when you've got the crush in extremity and you've got an IV and you're going to preload them, you know, with a liter or two that we talked about of crystal, you can also put bicarbonate into the, you know, put an amp of bicarb into the liter bag of saline, and that will help with the reperfusion, trying to prevent that reperfusion syndrome.
Unless you're in a completely isolated area and don't have transport out, you're probably not going to see that in a boot. Now, if you were on Galveston Island and had to wait for a helicopter, you might see it briefly before you transferred them out. But it kind of depends on where you're at, how isolated you are, and how shut off from everybody else you are. The guys that went down to Galveston were on the island and took over the hospital and essentially were there by themselves running an urgent care in the front part of the hospital. So, I mean, yeah, they saw some pretty severe injuries, but those they had essentially a constant flow of helicopters taking out. If that helps a little bit. They shouldn't be there for very long, let's put it that way.
Any other questions? Okay, well, if you think of some and you want to find me, you know how to get hold of me.
I was going to say, that would be like saying, would we see reperfusion injuries a lot in the ER? Not likely, because that's the kind of patient that's generally going to be rushed either to OR or out of the ER pretty quickly.
You
do the fasciotomies in the book? I mean, in the field?
You have if you have to, you have to. I would say.
Yeah, I mean, if they need a fasciotomy, you can do it wherever you got to do it. Hopefully, you've got some pain meds with you, but no, I mean, ideally, you'd like to do it on a more controlled and sterile environment. But if it needs to be done, you're going to have it open to the world anyway. It's an open wound once you make it. So yeah, you could do it anywhere. Anything else? Okay. You're welcome. Trying to drag this thing with me. I think something else.